really safe or not? Living kidney donation is experiencing a kind of revival in recent years. The severe shortage of cadaver kidneys and the superior functional outcome are the two major reasons. Furthermore, living kidney donation allows preemptive transplantation, and most transplant centers regard living kidney donation as the preferred source despite the potential associated morbidity. Living kidney donation reduces the number of individuals on the waiting list for deceased donor transplant and typically lasts longer and allows elective surgery and shorter hospital stay and planned desensitization of the recipient and short time spent on dialysis as well as reduction of cost. This is a long list for donor preparation, meticulous assessment of the donor, starting from blood grouping till screening for cancer and serology. All the investigations in laboratory and radiology and immunology are carried out in order to select finally a donor. And we have to absolutely contraindicate some donors. That's small, young-aged donor and mentally affected and uncontrolled hypertension, diabetes also can be considered as contraindication. Body mass index if more than 35, malignancy, psychiatric illness, and nephrolithiasis, and persistent infection. Now I will go to the short-term risk for kidney donation. At first, mortality, operative mortality. Second is perioperative complication, starting from wound infection, bleeding, which can occur in 7.3% of cases, as well as the GFR of the donor. It roughly halved immediately after nephrectomy. However, a year after donation, it is expected to rise to 60 to 70% of the pre-donation level due to adaptive hyperfiltration in the remaining kidney. The median IQR in the initial 6 months interquartile range in the first 6 months was 34%. This reduction in the GFR. In an adjusted model done by Lara Fahmy, higher age, body mass index, and systolic blood pressure, educational level, African American, and males were associated with sharper decline, significantly. And following an initial drop, the GFR start to recover. But it start to recover and recover more favorably in young donors and not in all donors. This illustration is showing that the long-term recovery after, you can see here, this is the young age, and when we do nephrectomy, GFR decreased and then started to increase back and increase more at the end of the follow-up, 1 year. This is in the young age. If you see the old age, it does not recover easily. This is the adjusted model for post-deletion GFR, showing that in correlation with age, the recovery in the young age is better than recovery. This is the recovery for the young age, and this is the recovery for the old age. You can see that recovery in the young aged kidney is better. However, African American were associated with 1.4% decrease, and Hispanics with 1.6 increase in the GFR recovery compared to whites. And higher body mass index and systolic blood pressure, educational level, smoking, and meal were associated with lower estimated GFR recovery. Now, it was concluded from this work that post-donation estimated GFR decline and recovery varies based on donor characteristics, and younger donors have more rapid short-term post-donation estimated GFR recovery. Histological abnormalities that can occur at the time of kidney donation. This can be glomerulosclerosis, interstitial fibrosis and tubular atrophy, EFTA, mesangial matrix increase, arteriolar hyalinosis, vascular fibrous intimal thickening, and any histological abnormalities. These pathologies correlate well with the fate of this graft, the recovery after nephrectomy. In this, you can find here, this is a young age. It is recovering, patient with negative EFTA. The recovery occurs over time. This is for negative EFTA, but for positive EFTA, it's the same or even decline. So the original pathology of the grafted kidney affect the survival. The long-term risks for kidney donation are cardiovascular risk, diabetes, gestational hypertension and preeclampsia, proteinuria, malignancy, mental health changes, infectious complication, chronic liver disease, and end-stage kidney. I will present the view, different views from different areas in the world. Some with living donation and others deny living donation. With living donation, first is Hassan Ibrahim, maybe the next speaker after me. He have investigated $3,600. He is from Minnesota, and he found that survival and risk of end-stage kidney disease in carefully screened kidney donor appear to be similar to those of the general population. So he encourages donation. And most donors who were studied has preserved GFR, normal albumin excretion, and excellent quality of life. This is the survival for the donor and control in the work of Professor Hassan Ibrahim. They were nearly the same, with no significant difference between them. However, the glomerular filtration rate over time, it is increasing. And the albumin excretion, albumin to creatinine ratio is also increased with a low slope. And he found that the most important risk factor for reduced glomerular filtration rate after donation is age, that is, if it is aged kidney, time since donation, body mass index, and current smoker and female sex. These are the risk factors for reduced GFR. And the risk factor for albuminuria were time since donation, also female sex. And the risk factor for hypertension requiring medications are age and body mass index. And here he have described the quality of life scores. He describes that the state of health has markedly improved in, in the donor, and as well as the mental health also as well improved significantly. And this is the representing regression line for every patient. He have done a point, and this is the regression line denoting improvement of the physical as well as the mental health for donors. So the direction of his study was to encourage kidney donation. The same group from Minnesota, Professor Mattes, also described the risk factor for post-donation diabetes. He found that the age, increasing age, and female and high body mass index and smoking are the most important risk factor for post-donation diabetes, as well as hyperlipidemia, diastolic blood pressure, and smoking, decline of the GFR, and in white donors, this correlated, they are risk factor correlated with the development of hypertension in donors. Also, he described the risk factor for post-donation psychological problems, that there is decreased health-related quality of life. It is correlated with the risk factor for decreased health-related quality of life, maybe obesity, psychiatric difficulty, non-white race, or mental disorder, psychiatric disorder. And the risk factor for depression occur mainly in non-white race with longer recovery time, and in donor who is young at the time of donation, and maybe due to financial troubles. Decreased satisfaction with life due to financial problem and longer recovery time. Poor overall donor experience due to donor complication, psychiatric difficulty, and sometimes recipient graft failure, causing psychological damage for the donor. Another study done by Rizvi from Pakistan. He have investigated around 3,700 patients, donors, with regular follow-up, and as he said, that for 27 years follow-up, all-cause mortality was 4 in 10,000. 6 patients of his series have developed end-stage 5 to 17 years after donation, and proteinuria more than 1 gram developed in 28 patients, hypertension in 13%, and diabetes in 3.6% of donors. Creatinine clearance fall down from 109 to 78. 78 at 1 year, 84 at 5 years, and 70 at 25 years. And he found that there is significantly higher fasting glucose and hypertension in non-donors, as in the control group. And he have described that the risk factor for low clearance in donors were the age at donation, if it is elderly kidney, and low pre-donation GFR. Low pre-donation GFR. And the risk factor for persistent proteinuria were pre-donation proteinuria, male sex, smoking, and post-donation hypertension, and nephrectomy donations, that's time since donation. And the risk factor for hypertension were the age of donor and the body mass index and the time since donation. And he have also subclassified his patients. بدي متأخر يعني. he has subclassified the long-term safety for living donation, that the incidence of post-donation complication was hypertension on the top, low clearance, then proteinuria, diabetes, and end stage in the bottom. And this is the risk done by Messi, is risk prediction of end stage. He found that more than 50% of donors lie in this line, whereas there are some few individuals have substantially higher prediction index. Yes. Male 6, regarding the risk prediction, at first, male 6 was highly correlated with graft failure in the stage, and African American, age after donation, and then if the patient is non-related to the recipient, and body mass index. Now, these two authors were with, these are key papers, they are with donation.
Time is off.
لا ده هم في الأول خدوا بتاع 10 دقايق عشان يظبطوا الجهاز. يعني هم بدأوا لي متأخر. حاضر. There is some contradictory view that donation is not safe, written by Mogen and Muzel. They have described that donation is a risk factor for the hazard ratio for death is that living donation is the most important risk factor for death after donation, as well as a risk factor for cardiovascular death in donors, kidney donation, as well as a risk factor for end-stage kidney disease in donors. This is another view, Smuzel. He found that live donors have بس أنا دقيقتين وخلص.
Conclusion دكتور ها؟
حاضر. افتح يا ما بتتحركش. So there are two views against. They are one from Denmark and one from USA, said that live donation is not safe procedure. تعبتوني خالص والله. Last slide for me. We have studied end stage in Mansoura. We have studied the incidence of end stage in Mansoura. It was out of 2,000 living kidney donors, 8 developed end stage kidney disease, 6 were men, and renal failure occurring 5 to 27 years after donation. Causes of end stage were hypertension in 7 patients, diabetic nephropathy in 3. Other possible causes include toxic nephropathy, chronic pyelonephritis, and preeclampsia. These are the causes for end stage in our group. And finally, living kidney donation remain safe and acceptable surgical procedure. Recent studies have provided evidence to estimate end stage kidney disease risk in donors and have demonstrated numerically small increase in end-stage risk and identified those groups at risk. That's Black donors, young donors, donors genetically related to the recipient, and donors with increased body mass index. Importantly, the absolute risk of end-stage donor remain low when compared to general population. This data must inform donor assessment and consent and emphasize the importance of long-term donor follow-up. It's recommended that every effort should be done to select suitable donor to ensure good functional outcome for recipients with no or minimal morbidity for the potential donors. We have to push forward the seized donation program to go in parallel to live donation. Thank you.
Thank you. Thank you, Professor Ehab, for this illustration.